Good afternoon, everybody. We'll be starting our general practitioner session 125, a practical approach to IOL fixation in absence of posterior capsular support and overview. This is a very common situation faced by anterior segment surgeons. And the first question comes in mind, why is scleral fixated IOL? When Kelman ACIOL is a gold standard in cases of absent posterior capsular support and easy to implant, and not much of hoopla about this. But the reason why I am pushing for scleral fixated IOL was because of this patient. This patient had a subluxated lens, underwent cataract extraction with an ACIOL implant. Both eyes, you can see good PI, round pupil, good vitrectomy done. Was maintaining 6/6 vision till last 1 year, when patient came with a sudden decrease in vision in the right eye. And if you see the right eye, you can see there is an bulle here, there is a decompensation of the cornea. We did the specular microscopy of the other eye, and the specular microscopy was 700. So 11 years down the line, the patient realized he got the surgery. What the surgery, he got it done 10 years back. Because of that surgery, he is at a verge of blindness, where he needs an IOL explantation within penetrating keratoplasty. So the idea is to place the lens in its anatomical position, that is posterior chamber, away from the cornea, behind the iris. So the concept of scleral fixated IOL came in cases of absent posterior capsular support. If we see the evolution of IOL till generation 4, IOL were either angle supported or iris supported. Success in IOL technology came when the PCIOL or the modern IOL were discovered, and we started putting the lens uh, in the bag, and in the bag lenses has a higher uh, 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 eye, where the lens was placed in the bag were quieter, did much well as compared to the lenses which were placed in the ciliary sulcus also. So in absence of posterior capsular support, the best way to go is SFIOL. And we have 6 speakers here. Technique and our experience will be with glued scleral fixated IOL will be discussed with Dr. Ritesh Narula. Uh, Gabor Shariat technique, that is no flap, no suture, no glue, and newer modification to it by Dr. Naresh Babu. Dr. Venkatesh will be discussing about his technique, what he has developed with Dr. Bhaskaran, XNIT, and Yamanei Technique, which is becoming more popular. He'll discuss about the fallacies and problems what you have in Yamanei's. And Dr. Rajesh Shina will be talking about root IOL with scleral fixated IOL, because many of the patients where you have decompensated cornea, you have an ACIOL, and Dr. Gitansha Sasdev will be looking upon posterior iris claw lenses, which is also a viable option. Now I'll invite Dr. Ritesh to share his screen and talk about his experience and the basic technique of root scleral fixated IOL. Dr. Ritesh, please.
Thank you, Dr. Gupta. Thank you for giving me this opportunity to be a part of this wonderful surgical course, something which I owe you as a teacher for initiating me into this almost now 8 years back, and never look back. We have had a great experience with this, and I'll be sharing my experience. I'm sharing my screen now, sir.
Yeah.
Is it okay?
Yeah, I can see your screen.
Right. Thank you. My video is not visible, right?
Yeah, it's visible now. It was visible, Ritesh.
Sorry.
Yes, we can see your screen.
Thank you. Very good afternoon to all. I'll be starting this session with talking about the basic technique of glued IOL, how to go about it. I'll be going a little slow in the initial surgical steps, and I'll also be sharing what our experience has been over the last decade using this procedure. So as Dr. Gupta was talking about in his initial slides, IOL implantation in the absence of posterior capsular support, the options that we had have been anterior chamber IOL conventionally. We have options of iris fixated IOL, and we have been doing scleral fixated IOL with the help of sutures. And now with another option that we are using now is the glued IOL technique. Now I'm comparing. Dr. Gupta talked about ACIOL and its disadvantages there. I'll talk about how we moved in from sutured scleral fixated to glued IOL. The limitations of sutured scleral fixated IOL basically has been the amount of surgical expertise required there. The glued IOL is a lot much easier to perform. The surgical time taken with sutured IOL is longer. The suture always stays as a foreign body and can induce inflammation. It's proline sutures which are used most often. Sutures degrade over time. These proline sutures do not cause any kind of fibrosis around them which can hold the haptic later. If the suture degrades, the IOL drops in. So delayed IOL subluxations and dislocations have been noted because of broken sutures. So that's how our thinking was when we shifted to glued IOL. So there are three basic components of a glued IOL surgery. You need most often a three-piece foldable intraocular lens. The basic surgical technique involving haptic externalization. Throughout this session, you'll be seeing the different approaches to do that, and what we use as fibrin glue to seal the tunnels. So this is the basic IOL which you can use. You can use either there's no financial disclosures here. So you can use either a J-loop haptic Alcon MA60 lens or a C-loop Technis or a sensor. These are all hydrophobic acrylic lenses which we use. We commonly use the Alcon MA61 with blue PMMA haptics. So the J-loop of the Alcon lens gives us a little more advantage. Some people do prefer the C-loop of the Technis lens also. The fibrin glue basically consists of two components, the fibrinogen and the thrombin component. There's an applicator with two mixing chambers, and once the two components get together, it forms a nice fibrin sheet over the area you want to seal. Now coming on to the technique of glued IOL. So the basic surgery involves initial steps as putting in two scleral flaps about 3 millimeters, 3 millimeter by 3 millimeter at 180-degree vertically opposite. So this is the basic surgical first step of surgery, wherein you make these flaps, put in your infusion. If you want to manage any anterior segment issues, like in this case, there was the lens which had to be removed, a superior scleral tunnel is made. Initially, it is recommended to make a large tunnel. Later on, you can shift to the injectors. You grasp the tip of the haptic with the help of a glued IOL forceps. It's important to grasp the tip under this flap. You do it from one side, you get it out from the other side. Subsequently, you make your grooves in the wall so as to tuck these haptics under these flaps. You can put these haptics in these grooves. And herein the haptic goes into the groove. I'll talk about the advantage of doing this step later. And then subsequently, you dry this area, switch off the infusion, dry it, put in fibrin glue. So here is the two different, the fibrinogen and the thrombin particles are being put. And then you seal the flap, you press it hard till the fibrin sheet is formed in that area. It holds the haptic in its place nicely and seals the entry wound also. Now this entry wound under the flap can be made either with a 22 gauge needle, or even nowadays I'm using 23 gauge or a 25 gauge trocar cannula system. Also, you can make these openings under the flap with this. Now the advantage of putting these haptics in this groove is that once you put them in the groove, it does not, it prevents the forward and the backward movement of this haptic, so that phacodoneesis post-surgery is much less. So this movement of the haptic is kind of stopped and the haptic stays in one place. So as I was talking about phacodoneesis, in cases wherein the sutured SFIL was done, the IOL actually hangs like a hammock from the two sutures. The sutures are in the sclera and the IOL is hanging like a hammock. So with every eye movement, the IOL tends to move. So there's a lot of phacodoneesis in sutured IOL. While in haptic externalization SFIL technique, or the glued IOL technique, once the haptic is out into the tunnel, it has a better centration, there is lesser tilt, and the IOL is more stable. So as we said, so there are no suture-related complications, there is less surgical time involved. At often, if the patient has had issues with his previous three-piece IOLs, they can itself be refixated. You don't need any special scleral fixated IOLs with eyelid that was required for sutured IOLs. And the indications is huge in which in which this procedure can be done, starting from traumatic cases to intraoperative complications of cataract surgery to subluxated natural lenses in cases of Marfan's or homocystinuria, etc. Now, there are certain modifications to the standard procedure. I'm not talking about technique of externalization, it's brief modifications here. You can use an injector system also to inject. Again, the trick here is first hold the haptics, leading haptics, only the tip. Inject the IOL, let it unfold completely into the anterior chamber and leave the trailing haptic outside the tunnel. Take the first haptic out, hold it with a handshake technique. Again, grasp the tip of the haptic. The lagging haptic, take it out under the flap, and you have both the haptics externalized now, and then you can tuck them into the groove as we talked about in the standard approach. You can fixate a dropped IOL itself. So in this case, there was a dropped IOL there. I'm using a chandelier light to illuminate the eye, pick up the IOL with one hand, use the other side to grasp the haptic with a glued IOL forceps. You see, there's a slight bend in the haptic because probably I was not exactly at the tip. Luckily, I was able to straighten it and then put it into the groove, and you can fixate the same IOL and remove the chandelier light later. So the complications, we have seen quite a few of them more during our initial early stages. As you become more experienced, the number of complications keep going down. Coming to our experience, over the last decade, we have done more than 1,000 eyes, and this is a data of almost 1,000 eyes with follow-ups from 6 months to as large as 6 years. The most common indication have been surgical induced aphakia, other have been subluxated lenses and subluxated malposition IOLs. And we have had good success with our visual acuities also. More than 78% eyes had a visual acuity better than 20/40. These are the causes in patients in which there were other causes which eventually led to a poorer vision, such as hemorrhage or a corneal scar, or patients who were post-keratoplasty. Obviously, the results were not as gratifying in terms of visual acuity, though IOL centrations were good. So just to share a few of our cases, this is a Marfan's patient who underwent glued IOL, both the eyes. This is an anteriorly displaced PC IOL, and this is the same patient post-surgery. Another patient, so just showing few of our stories wherein post-trauma case wherein an esophageal was done. And coming to the complications, the issues that we had, the common ones were vitreous hemorrhage from the sclerotomy site. It can happen initially at the start of surgery. We have had to postpone a few cases because of that, when the hemorrhage was in quite a bit, but you can see the numbers are very few. Haptic bend and break on externalization. Initial surgeries, quite a few happen, but once you get a hang of the surgery, the importance of grasping the tip, this becomes quite less often then. We have had exposed haptic in 12 eyes, an IOL dislocation in 6 eyes. These were generally eyes in which, but in my experience, I have seen the larger eyeballs, higher myopes, thinner sclera, where the IOL does not get the sclera is not able to hold the IOL very nicely, or you have not chosen the right meridian to put in the IOL. It's advisable to first check which axis of the cornea has the shortest chord length, so that you can use in such eyes, so that you have enough haptic getting externalized. So you can either do a vertical fixation or at an angle fixation also. Amongst complications, we had scleral melt in about 2 cases. This is one of the patient wherein, and the most common feature which I feel in these cases where you have a melt is when the conjunctiva retracts and this flap area doesn't get nicely vascularized. This causes the haptic to get exposed, and this patient required a patch graft. So in conclusion, fibrin glue fixation or the glued IOL is a safe an effective technique in comparison to suture fixation or PCIOLs. It can be employed in a lot of complicated cases also, as my future speakers would be talking about. The surgical time is significantly less. The patient comfort is a lot more. We have seen about now, we have been doing it for a decade, a long-term stability, I would say. And you don't need any specially designed IOLs. And it can be done in multifocals and aniridia IOLs also. So, thank you.
Thank you. Such is the success of the glued IOL or scleral fixated IOL that in our center we have stopped doing any AC IOLs and we have totally shifted to scleral fixated IOL. Any new person who joins our center doesn't know, learns the technique, and he also has a lot of appreciation about the technique. And he says he only few tricks. One thing what I'll like to add to the beautiful presentation of Dr. Ritesh is that good vitrectomy is a must to the key of success. Once initial 30 cases, I was not doing a total vitrectomy, past planar vitrectomy. But once I started doing a total vitrectomy, my results drastically improved. I'll go on to Dr. Naresh Babu, who is head of the department Retina Services, Arvind Eye Care System, Madurai, to share his slide. First, we'll cover all the techniques, then we'll go for a discussion. Dr. Naresh. We can see your slides, Naresh. Can you unmute yourself? We are seeing your slides, but I can't hear your voice, Naresh.
Yeah, I think, yes. Sorry for that. Okay. This one? Where is this? Where am I? Yeah. Just over 10 seconds.
Yeah, sure.
I have some issues here.
Stop share பண்ணி வேணா reshare பண்ணுங்க.
இல்ல நல்லா இருக்கு. இங்க I have some issues with the.
You have to only go to full screen. That's all. I can see your slides.
Yeah. No, I'm seeing, but I'm not able to see. Okay, then okay. Right. You can see me, right? Now it's fine.
Yeah, I can see. Yeah.
Okay,
now
right.
I can
Okay.
see.
Yeah. Thank you, Dr. Avnindra. So this course, I think we have been doing for the last almost 8-9 years. Thanks to Dr. Avnindra for giving me an opportunity. Today, I'll be discussing how to manage aphakia with a sutureless esophageal by Gabber's technique. So I'll skip all these things because it has already been spoken by Dr. Ritesh. So we've got a lot of options like secondary PC IOLs or scleral fixated IOLs by various techniques, glued IOLs, iris sutures. I'll be basically talking about a no flap, no glue intrascleral IOL fixation, which was basically designed or told to us by Dr. Gabber Scariath. I know I've been always a brand ambassador for Gabber Scariath because he's one of the fantastic surgeons I have seen in my life, and I had the opportunity of meeting him personally and staying with him for close to 2 weeks. This is Dr. Gabber who first gave us this SF-IOL. So the basic difference between the scleral fixated IOL and glued IOL is, except for the glue, the procedure is almost going to be the same, but it will not be raising the flap. So I'll just go step by step how we do a SF-IOL. So this is a case of first, what we do is basically, it's a case of a subluxated lens you can make out. So after doing a localized peritomy, here I am going to fix a 3-piece rigid lens. That's the reason I have done almost 270-degree peritomy. But nowadays, most of the time, if the patient can afford, we can go for a foldable lens. Nowadays, I've started using Oro Labs Oro View, which is a 3-piece foldable lens, no financial interest. That is quite inexpensive and very good for this technique. So we have to make 2 scleral pockets. I use a 23 gauge MBR blade. Initially, I was using 24 gauge needle, then the trocar. Now I am very comfortable using a 23 gauge MBR blade. You can make out. I am just holding the muscle just for the support and making 2 pockets. One 80 degrees away. The most important thing is what I keep telling is, like, you would have found that almost 12 cases of Dr. Ritesh had vitreous hemorrhage. So that happens because when we make the pockets at the 3 and 9 o'clock meridian, because that is the site of entry of long postciliary artery. So when we are making the pockets at the 3 and 9 o'clock, there is every chance that we will be having bleeding while entering into the vitreous cavity. So I always tell our fellows, sir, I also follow that. We are slightly eccentric in the sense 2 and 8 or 4 and 10 o'clock meridian is fine. So slightly 1 or 1.5 clock hours away from 3 and 9 o'clock is fine. So after making 2 scleral pockets, this is just an animation, 1.5 millimeter posterior to the limbus we make with MBR. So it's not a through and through, it need not be through and through. So on either side, 180 degree exactly away. And if you're going to do it for the first time, you can use a marker, but usually it is not needed. But see to that your 180 degree, it should be 180 degree apart, otherwise it causes a slight decentration. After that, this is the usual scleral tunnel for a subluxated lens. And if it is going to be your foldable lens, you can go for a clear corneal incision where you can use an injector to inject your IOL. But here I am going to use a full, rigid 3-piece PMMA lens. That's the reason. After entering into the vitreous cavity, this is another case, I think. Okay, we'll just go. We have to enter the vitreous cavity with the help of a 24 gauge IM needle, exactly at the end of the scleral pockets where we have made on either side. So just to give just a 0.5 millimeter gap between your scleral pocket and the entry you made, otherwise a lot of haptic will be exposed. So once it is done, we can use, this is a rigid PMMA lens. I am using a Gabber forceps. You can see, you insert the lens. Always hold the tip of the haptic. So if you hold the shaft of the haptic, there is every chance the haptic will be broken and you'll have to replace the lens. The most important thing about tucking the haptic is don't tuck too much, just into the scleral pocket, hold the tip and tuck. Being a vitreoretinal surgeon, I am very comfortable putting the second haptic into the vitreous cavity so that it is easy for me to pick it from the vitreous cavity. And again, the Gabber's forceps which we are using to insert the haptic, it is a pair of forceps. One is a curved one, the one which we are using. The other one is a straight, which is used through the sclerotomy to pick the haptic from the vitreous cavity, and it is a 25 gauge, and it is even though it's disposable, it can be used for so many cases. So after excising the haptic, straight away you tuck it so that the second haptic will be in the vitreous cavity. So this is how we pick the second haptic. You can do it by handshake technique also. So I have held the tip of the second haptic, and usually I use a forceps and just keep supporting on the sclera to give a counter pressure. Okay, when you give the counter pressure, when you externalize, it is easy actually, otherwise it will be having a pulling effect. After holding, you can make out, we always hold the tip. You can see the curved Gabber's forceps, curved tip, just to go into the scleral pocket which is made and tuck it sufficiently. In case if the other side is over tucked, you can release it with the thing. So this is a case where we have done a lensectomy. Same, actually the pockets are made. And here the lavitation is done. As I have told, we are entering into the vitreous cavity with the help of a needle, just 24 gauge IM needle. Once it is done, use a Gabber's forceps, or you can use any forceps. You can use a 23 gauge or 25 gauge. This is again a rigid lens, 3-piece PMMA. So it is quite inexpensive. Just hold the tip, never the shaft. The most important thing is when the tip is snipped more than 2 millimeter, we always advise to replace that lens. The reason is if the tip is snipped more than 1 millimeter, there is every chance that post-operatively one of the haptic can dislocate because there is no sufficient length of the haptic. So this is the POD one of the case which we have done, and these are the other cases where we have done this technique. So the basic the advantage of this technique is there is no cost for the glue, and it can be done with any 3-piece, either foldable or a rigid lens. And nowadays we stopped even doing the conjunctival flaps. You can do transconjunctivally also. If you want to do it comfortably, go for what you call the Gabber's forceps. Otherwise, you can use any of the intraocular forceps. So these are the few cases. The advantages, it can be done in a dislocated lens, or provided it is a 3-piece dislocated lens, you can use the same lens. It can be used in cases with IOL, CTR complex dislocation, can be combined with any of the corneal procedure, and it can be used in traumatic lens also. The most important advantages, like same as what you call the glued IOL, you don't need any, a special haptic architecture. You don't need to have special inventory. You can use the 3-piece lens which is available in your inventory. But the limitations are only 3-piece IOLs can be fixed. Silicon lens or other single haptic cannot be used, because that single haptic, single piece IOLs, the haptic can degenerate or it may break while externalizing. And these are the complications which has already been discussed. I don't want to discuss again. And a few of our publication, this is our publication on evaluating the sutureless, glueless, flapless for pediatric age group. So it was done in 40 of the 25 eyes patients with a mean age of 13 years, with a standard deviation of 3 point plus or minus 3.7 years. Usually SFIOL I don't do in children less than 7 or 8 years, because that is the time you get the proper scleral rigidity. So the conclusion of this trial was the refractive error induced is very, very minimal in these lenses. Of course, we'll have to correct depending upon the age. It is a suitable procedure for children who are non-compliant with spectacles. And the complication profile is almost similar to that which has been reported in the adults. And another publication is we have analyzed our cases in the past 3 years, where we have done close to 1,311 eyes. So these are the complications and the indications, and we had almost 1.7% of the eyes developing retinal detachment. As it was moderated by Dr. Avnindra, RRD happening in these cases, managing the vitreous properly, especially at the site of sclerostomy, where you have to clear that area completely of the vitreous. Having the vitreous and doing this procedure in the presence of vitreous can lead to traction and can lead to this complication. And in fact, one of the worst thing which we have come across in this study is like almost 70% of the eye reattached with one surgery, but nearly 1/3 required more than one surgery. And if you see, the final reattachment was only in 76%, which is much lesser than a primary regmatogenous retinal detachment. So once RD happens in these cases, we found that the complication is very, the PVR changes are very advanced. Managing them is very difficult. And the last study which we have published is on 10-year trend on the incidence of esophageal. If you see, actually the culture positive endophthalmitis is only one case actually. So it is almost similar to the rest of the endophthalmitis which we get in post-IOL. And the latest publication was done by one of our fellows, Dr. Saurav. He has published in 2021 IJO. So he has given a frugal model for the trainers how to do it. Actually, people who are interested in doing this technique can refer to this article. And before concluding, I would like to tell that this is a wonderful technique right from the pediatric age group to the old age group, used with any of the 3-piece. And there is no need for any what you call the glue, and a very simple technique to practice also. With that, I would like to conclude, and I would like to thank Avnindra for giving me this opportunity. Thank you, Dr. Avnindra, and thank you once again.
Thank you, Dr. Naresh. A very nice presentation. Actually, what I insisted before, you have put an add-on to that key vitreous management is a must in these kind of cases. And maybe the incidence is pretty high because the eye what we are tackling is all complicated eye, trauma, subluxation, and post-operative complications like PCR, vitreous mismanagement, vitreous traction. So incidence of regmatogenous retinal detachment will be higher in these group of patients. And we also know if you have a dropped lens or a dropped nucleus, the success rate of regmatogenous retinal detachment is lower as compared to the normal regmatogenous retinal detachment. With this nice talk, we'll go to another technique that will be Dr. Venkatesh will be sharing his slide. Dr. Venkatesh is a Chief Medical Officer of Arvind Eye Care System, Pondicherry, and is a high volume surgeon and is looking after academics. And last year, I think he had the maximum number of publications from Pondicherry. Venkatesh, please.
Hello, friends. Welcome to our general program. I take this opportunity to thank my good friend Avnindra Gupta for asking me to talk about an innovative way of fixing SF5OL, which was developed by one of my good friend and colleague, Dr. Prabhu Bhaskaran. So this technique, we named it as XNet, where it is actually an extraocular needle-guided haptic insertion technique for sutureless scleral fixation of IOL. You all know the genesis of sutureless scleral fixation. Again, my good friend, Dr. Gabbard, made this chariot tunnel, and then he came up with an excellent way of fixing the PCIOL, especially the 3-piece PCIOL, into the sclera, so that you don't have to fix it to iris or do a suture way of fixing it to sclera. So he did a sutureless way using a chariot tunnel. And brilliantly, Dr. Amar Agarwal converted this technique into glued IOL technique. So because most of the people were finding it difficult to put the haptic into that scleral tract, the small point where you have to enter. So it was very difficult for many of the surgeons. So that is where innovation comes, making it simple. So under a scleral flap, so when you make a track here, it is very easy to insert the haptic and then glue the flap. So that is basically the glued IOL technique, and which became popular across the globe. And then came a brilliant idea, an award-winning idea in ASCRS. Now it's published and it's also adopted by several surgeons across the globe, called the Yamanei Technique, developed by Shin Yamanei from Japan. So what he did was, he took a 26 gauge needle, and then he made a scleral track. And then after the track, he entered into the vitreous, and then you thread the haptic directly into the needle, and then you remove the needle so that the haptic does the scleral track also continuously. So you don't have to remove the haptic and then again insert it into the scleral track or the chariot tunnel. So you can do this as one single step. Again, a brilliant idea, which became very popular, because any step which is difficult, if somebody makes it easier, then I'm sure it's a great innovation. But again, the problem here is the handshake, where you have to do the handshake inside. A lot of people who are not used to doing anything behind the pupil, especially in the anterior vitreous, find it very difficult. Like this, you try to shake, but she's not very comfortable. So it's very difficult for the handshake to happen, like you see here. So many of the times it can slip. You try to hold it with 2 of your forceps, but it can slip. So this sometimes can take a very long time for some surgeons. It can be so too long to kind of hold on to that to finally exteriorize the haptic. So these are issues with the handshake technique which still exist. So that's where the technique of XNet comes. So basically, what happens here is, whether you do a glued IOL or the Gabbard way of doing it. So you insert the needle through the sclera behind the iris. No, it's actually a bent needle. At a certain angle, it is bent, and there is a small stopper also, if you see here. And then you exteriorize the needle. That's the best part in this technique. Through the pupil, through the tunnel, you use your McPherson's forceps to gently open up the valve of your SICS tunnel. And then you exteriorize the needle. and you thread the haptic here. So here you don't have to do a handshake. You don't have to make that step much simpler. And then you exteriorize the haptic, and then you put a stopper. The stopper really keeps your haptic intact. So when you are manipulating on the other side, you will not lose this haptic inside. This happens for some people, and that is also really cumbersome sometimes. And the same you do from the other side. You exteriorize after you are doing this technique. And now it's up to you. If it's glued under the flap, or if you're doing a chariot tunnel, you have to really try to pull it back and then insert it into the chariot tunnel, and then you complete on the other side. So this stopper with the exteriorization really helps to make this simple, this complex procedure very simple. But the only issue is you need an SICS tunnel because you are doing with a rigid lens. It's not a foldable lens. So you're doing with a rigid PMMA 3-piece lens. Let's see how we can practice this in wet lab. So all the steps can be beautifully practiced in a goat's eye or even a cadaver eye in wet lab. The sclerotomy is like what you see is 1.5 millimeters. And then you use your McPherson's to open up the valve and then exteriorize the needle. And then you insert the haptic. You get it inside, and then one stroke, you exteriorize the haptic and you put the stopper. The stopper will make sure that the haptic doesn't go inside again. And then the same you can do. If the chamber collapses, you can put viscoelastic into the goat's eye, or you can even use formalin. And then you insert the haptic into the needle. And then this step is a little tricky. You have to gently go inside and then start exteriorizing it slowly. And when you come out, when the haptic comes out, you catch with the McPherson's and then you remove the needle. We have seen that this technique is really useful when you have corneal opacities. When the visualization is very poor, this technique is very useful. So this is the chariot tunnel being made using a MBR blade. And the chariot forceps really helps you to put the haptic into the tunnel. And you can see in this hazy cornea, you can beautifully bring the needle outside, and then you can do the threading, because it's so difficult to do inside when you have such a poor visualization. Here, after the SFIOL, they're going to transplant the cornea, and you can see the stopper, the silicone stopper. Once the stopper is in place, then you remove the needle from the haptic, and the same you can do from the other side. So somebody can help you in positioning at this point, because you have to do an acute bend of the haptic to insert into the needle. And then we need to gently externalize it. And then using a chariot forceps, you insert that haptic into the chariot tunnel. Following which a keratoplasty was also completed. So now this kit is developed by, I have no financial interest, Oral Lab now does it. It's called the XNet kit. You have in the back, you have markers, which is 4 millimeters and 1.5 millimeters to mark exactly. 4 millimeters is for the chariot tunnel. 1.5 millimeters is for the scleral entry. You have a nice finger grip. It's a 26 gauge needle, which is bent at exactly 40 or 45 degrees, where you need the bend for comfortable exteriorization. And you can see now the stopper is a double stopper. So it is placed in such a way that even if you lose the haptic on one side, still the other end is intact. So that's another brilliant idea, which is now into this XNet kit. This is a double stopper or the double protection which you are seeing. So even if you lose one side, the other side is still inside. It is a magnified view. It's a 60-degree bend. This is a close-up of the double stopper. The close-up view of 1.5 millimeter mark and a 4 millimeter mark. And that's the kit which is now readily available. You can use one for your left side, one for your right side, because the kit has got both the ones, and then you can dispose it. It's less expensive. And the silicon softer, this is how it works. The double protection works. So even if you lose one side, when you are manipulating the other side, still the haptic will be inside. Again, I take this opportunity to thank my good friend Avnindra Gupta for conducting this excellent instruction course in our virtual AIOC. Thank you.
Thank you, Dr. Venkatesh. It was a wonderful presentation. And I do remember there was one Surginar when this surgery was presented. The Surginar was conducted by AIOS, and Dr. and myself were there, and your colleague had shown this technique. So this looks wonderful.
Dr. Prabhu, the innovator, was the surgeon for that day.
Yeah.
It was well received. I think it was one of the well received surgeons in your period.
Yeah, absolutely. It was.
I remember seeing 21,000 plus views or something like that.
Yeah. So that was
a brilliant idea and technique which makes things much simpler for others. I mean, that is our duty as surgeons, as good surgeons. We need to make even an average surgeon do well. And that is what I think XNet has done. And of course, glued IOL, again, to make that insertion is again another difficult part. So glued IOL with the XNet would make anybody do comfortably a sutureless scleral fixation.
Absolutely.
Yeah.
True.
Hall coordinator, can you make my video on? Mr. Purnesh?
So next we have Avnindra Gupta, right?
No, next we will go on to the other technique that is iris claw lenses by Gitansha.
Okay.
Then Rajesh, you can start with cornea.
That's fine. I'm free now.
सर अपने साइड से आपको कैमरा ऑन करना पड़ेगा.
Is my screen visible, sir?
Yeah.
Very good afternoon. At the outset, I'd like to thank Dr. Avnindra Gupta, sir, for this opportunity. So my talk today is on retropupillary iris fixation of the intraocular lens. I have no financial disclosures. Now, there are various choices available when one talks about inadequate capsular support. The anterior chamber IOLs have largely fallen into disrepute, essentially because of the endothelial decompensation that they cause. Scleral fixated IOLs and the various techniques have been very comprehensively already taken upon by the various speakers. However, as Dr. Avnindra sir has mentioned earlier, that it does, for the results to be very good, it does require a complete vitrectomy, which falls under the purview of a posterior segment surgeon. The iris fixated IOL, on the other hand, simply entails the fixation of the IOL behind the tissue, and all one needs is a good vitrectomy at the pupillary margin or the pupillary plane, which can also be done by an anterior segment surgeon. The other advantages include that the procedure can be done under topical anesthesia. Unlike the predecessors of the AC IOLs, there is no anterior chamber shallowing, and it is thus gentle on the corneal endothelium. Additionally, there are no sizing issues. As I've already mentioned, as against the SF IOL, the learning curve is much shorter as it requires minimal vitreous manipulation for an anterior segment surgeon to do, and it can also be used in open sky procedures and hazy corneas. Now, a short overview regarding the lens. This is a non-foldable UV PMMA lens. It does require either a scleral tunnel or a larger corneal incision of about 6 millimeters or so for the insertion, with an overall diameter of around 9 millimeters. The A constant varies from 115.8 to 117.2, depending on whether the inflammation is done anterior or at the posterior iris plane. So the procedure is very simple. The main step here is the enclavation. They should not be done in a dilated pupil. The pupil should be maximum mid-dilated because the enclavation is done at the mid-periphery of the iris. One simply introduces the lens through the corneal incision, following which it is horizontally oriented so that the haptics are near the two side ports. Then we go on to hold the lens with the IOL holder and introduce one side of the lens behind the iris. The lens is then slightly pushed up and the iris is indented into the pincer-like haptics. The process is then repeated on the other side. So this is just a short video which will show the procedure. This is a case of sclerophakia where you can see that there is a gross loss of sonules. So we've essentially planned for a lens extraction along with the bag. So scleral tunnel was made here. This is followed by a limited anterior vitrectomy. The lens is then placed into the anterior chamber and is dialed into the horizontal position. So these haptics are near the areas of the side ports. One part of the lens is introduced under the iris, followed by the second one, and then a Sinskey is used to enclavate the haptics. It is important to do a thorough viscoelastic wash both in front and behind the lens to prevent postoperative IOP spikes. Now, another advantage of these lenses is that it can even be done in hazy corneas. This is a case of a long-standing aphakic bullous keratopathy. We've just debrided the epithelial for certain better visualization, followed by an anterior vitrectomy, which is done essentially at the pupillary plane to make sure there's no subsequent traction with the subsequent maneuvers. So we're making a corneal incision here of around 6 millimeters, both for the insertion of the lens and subsequently for the DSEC corneal donor, the graft. The lens is again rotated around the horizontal position, and the optic is held by the IOL holding forceps, following which it is tucked under the iris and enclavated. Now, the enclavations are actually fairly strong. You can see that after the DSEC donor has been placed, we will do a good air fill. And at this time, the pressures are fairly high of about 50 to 60 millimeters. And you can see that the lens does not disenclavate or require re-enclavation. Even when the iris is slightly less or there is a certain loss of tissue, such as this case where a large sector iridectomy has been done, one can just do a small pupilloplasty, following which an iris claw lens can be implanted. This is a case of a disenclavation which was noted 4 years postoperatively following a small history of trauma. All one has to do is to retrieve the lens into the anterior chamber, following which the pupil should be constricted. And then the lens is again held, pushed, the haptics are placed behind the iris and are subsequently tucked. Now, some of the concerns with the ACIOL would be any endothelial cell loss, which may happen. Also, since we've enclavated a small amount of the iris tissue, there could be slight amount of iritis or pigment dispersion, which could be associated with raised intraocular pressures or cystoid macular edema. However, long-term outcomes of iris clip lenses have been studied. This is one of the landmark publications wherein 320 eyes with a mean follow-up of 5.3 years were included. You can see that most of the eyes were either post-trauma or an aphakia post-cataract surgery. It was additionally had a cohort of about 57 eyes combined with an open sky surgery of penetrating keratoplasty. Disenclavation was noted only in 3 eyes, of which 2 of them were post a minor trauma. Retinal detachment was as low as 1 eye, which could even be noted in any cohort with aphakia. One of the more common complications is iridodonesis or a pseudophacodonesis, but these are not visually relevant complications. No cases of uveitis or any significant change in the endothelial cell counts were noted. So I'd just like to conclude that the iris-fixated IOL has a quick learning curve. It requires a very limited vitrectomy, which falls under the purview of an anterior segment surgeon and has shown safety on long-term follow-up in numerous publications. Thank you.
Thank you, Gitansha, for the nice talk. Two things. One thing what I'll like to stress: whether you are doing scleral fixated IOL, all scleral fixated IOL either needs an cannula in the vitreous cavity or an AC maintainer. But for iris fixated lens, you don't need any cannula or an AC maintainer. So that is one advantage, because many of the people are worried how to insert a vitreous cannula into the vitreous cavity. But for them, AC maintainer is a good choice. You can keep an AC maintainer in your OT, and you can proceed in for or manage the complication. Rajesh, I'd like to ask you, as a cornea surgeon, how do you like this iris fixated lens? Whether you will prefer or you prefer a glued scleral fixated IOL? What's your take on this?
See, my preference will be a glued scleral fixated IOL. The reason for this is I have been, explanting disenclaved iris fixated lenses for patients, for children actually, after 7 years, 8 years, 9 years, something like that. It was more than 5 years, definitely. Between 5 to 10 years of implantation, there was a disinclination, it was hanging. Then I had to lift it up, and then I explanted, and I did a glued IOL. So what I feel is that it may be a good procedure, acceptable procedure in adults, like an older individual, wherein the lifespan is less. But in children, it should definitely be avoided. That is one. Second, because obviously because of a long life, the risk of iris atrophy and disinclination is high. That is one. Point number two is that even the anterior chamber, AC IOLs, the very size phakic implants that we initially started with the first phakic implants when we started was a very size one, which was the anterior iris clip, wherein the crystalline lens was also there behind and there was a support. There also disinclination was quite reported. So I feel that something which is hanging behind the risk of disinclination, particularly in children with a long lifespan, is a little high. So that is one reason why I prefer doing intrascleral haptic fixation.
And one thing always I feel there is a lot of pseudo-phacodoneesis in these cases.
A lot of pseudo-phacodoneesis.
And once you have a lot of endo-phacodonesis, the chances of CME will increase. That was one of the factors.
Both ways. CME will also increase. Obviously, the traction will be there. That will cause CME. There can be more things because of pseudo-phacodonesis. Then even the anterior chamber, fluid dynamics is affected. So there's constant movement of the lens, so that can have adverse effect on the endothelium as well, apart from, of course, CME, which is there.
Next, I'd like to invite Dr. Rajesh Sinha, who doesn't need any introduction. He is almost there in all mails of AIOS as a treasurer AIOS. But apart from his political designation, he's a prolific cornea surgeon. And we love to hear his talks because it's lucid and is well demonstrated by data and facts. Dr. Rajesh.
Thank you, Dr. Avnindra Gupta. And most importantly, I would also like to add one sentence in my introduction that I'm a good friend of Dr. Avnindra Gupta. And so thanks for involving me in this instruction course. I'll be talking about glued IOL with corneal procedures, and I don't have any financial interest. Now, there are certain indications wherein you do have to plan for an IOL, wherein you don't have a support. There's no capsule, nothing. In that case, either you put an anterior chamber IOL, or you do an iris clip lens, iris claw lens, retrofixation, or you do a SF IOL. Now, these things are there. But there are certain conditions wherein you can't even put an anterior chamber IOL wherein there is a narrow angle, iris badly damaged, and various other scenarios. Patient has to undergo an endothelial keratoplasty in a subsequent stage. So in such cases, you would want an implant to be a little further away from the graft endothelium. And that is why I prefer doing the intrascleral haptic fixation or SFIOL. I've also done sutured IOLs in these cases. I'll come to that in my later slides. So the indications will be aphakia with endothelial decompensation or with corneal scars. If there's a dense scar, then you would like to do a full thickness graft in order to have a better visual outcome. And of course, pseudophakia with corneal decompensation or scar with IOL in unacceptable position. So by IOL in unacceptable position, I mean to say that if it's an PC IOL, sometimes, it is put in the anterior chamber because of the panic, because of whatever reason. We do encounter many cases wherein the patient comes to us with a decompensated cornea with posterior chamber IOL in the anterior chamber, causing recurrent UGH, causing, tilt of the PC IOL, causing touching the peripheral part of the cornea. It's a IOL which is tilted, hanging, all sorts of things, or an AC IOL which is very close to the endothelium, causing decompensation, tilting, having bad synechia. So all these can be considered as IOL in unacceptable position, because the most acceptable position of IOL is in the posterior chamber, wherein it close to the nodal point of the eye, so that not only the refractive outcome is good, but also the distance from the endothelium and every part is in the most physiological aspect. It is in the most physiological relationship, having most physiological relationship with all the structures. So coming to the procedures that we can do, so coming to the options that we can do in cases wherein you have a corneal scar or a corneal decompensation, we can do either ultra-thin DSEC or a DMEC procedure with intrascleral haptic fixation of IOL, or you can do a PK full thickness graft with intrascleral haptic fixation of IOL. So this is just an example of a case wherein ultra-thin DSEC and glued IOL is being done. So the anterior lamella has been cut by a microkeratome, and then the posterior lamella is being fashioned, endothelial with a little bit of stroma. And then this is a case with an endothelial decompensation with IOL in unacceptable position, which is an AC IOL tilted, touching the endothelium. So in that case, the glued IOL is being planned. So normally what I do, I have slightly modified the technique which has been reported earlier. And I make a flap with a dissection adjacent to it, so as to create a groove in the same plane as the base of the scleral bed. So I'll come to that, why I do that and what is the rationale for that. So after doing all these, the Descemet scoring is done, and then the incision is enlarged, and then this the remaining Descemet, whatever is there, is removed, and then after enlarging the incision, the IOL is being removed. This is an AC IOL which was touching the endothelium at some places, and it was very close to the endothelium at some other place. So a stab incision is being placed at the scleral bed, and then a multi-piece IOL is being introduced. Since the incision is large, so I don't have to fold it. Otherwise, if it's a small incision, I will use it an injector. Tip of the haptic is held with a lens fixing forceps, and then it's exteriorized. And then the second tip is also exteriorized on to the other side. And once both the tips are exteriorized, it is tucked into the groove. Now, this groove is on the same plane as the scleral bed. So there's no bending, number one. Number two, the haptic follows its curve. So I don't create a chariot pocket. I create this adjacent groove with the dissection with the crescent blade. And this I had reported in Journal of Cataract and Refractive Surgery, which was published. So after fixing the lens, the endothelial tissue, the lenticule, is loaded on the Busen glide, and then it is introduced into the anterior chamber, and then air is injected to push this tissue against the stroma of the host, and then that is the end of the procedure. Now, what I wanted to tell you, not creating the chariot pocket and dissecting with a scleral, with the crescent blade, the ease, first of all, it is very easy to do it. Number two, when you are creating a chariot pocket, although it doesn't make a clinical difference, but practically speaking, it's just above the scleral bed. Point number three, you don't have to stain the chariot pocket. It's a small tunnel which is very easily seen, and introducing the haptic is also very easy. So what Dr. Venkatesh was telling, that you do innovations to make life easier for surgeons. So this is something which has really made life easier for all my residents, and everybody does this technique only. And this was published in the Journal of Cataract and Refractive Surgery in the year, I think, in 2013. So this is the post-operative picture of the case. Now, the point is that if you are doing an ultra-thin DSEC or any endothelial procedure, if you are doing it as a single stage, what we found out that, sometimes you have to do these iris manipulation as well, because these are complicated scenario. You have to do, say, something like pupilloplasty, whether you use a single pass 4-throw pupilloplasty or any other technique. Then the risk of inflammation is high in the post-op period. So the risk of damage to the endothelium is there, to the host endothelium, donor endothelium is there. So we just thought that whether if we divide it into two stages, whether it will help or not. And so in one group, we did a study, and in one group, we did this intrascleral haptic fixation with explantation of the previously implanted IOL, did all the iris manipulation, etc. Waited for at least 6 weeks, and then at a second stage, we did this endothelial procedure, and we found out that I'll just skip the video for the paucity of time. And we found out that the results were much better in sequential. So this was one study, a thesis given to one of my candidates, Hannah Shiny. She did all the procedures, and this was my idea to do a comparative study of Desmet stripping automated endothelial clitoroplasty with intrascleral haptic fixated intraocular lens in a sequential versus simultaneous approach. And we found out that the sequential approach had a better visual outcome on better graft survival. So this is something which I would like to emphasize. And if the scar is a bit thick, although this scar is not that much, it may require a DSEC, but this is a surgery, a video which is an old video. So, but if you have a central scar, in that case, you can perform all these procedures with the full thickness graft. Now, when you are doing a full thickness graft, once you cut the donor lenticule, you can either fix the IOL first and then go ahead with the clitoplasty, or you can just you can put the graft, put 4 sutures, and then go ahead and fix the lens. So I am not able to push it forward. Maybe just you'll have to have the patience. So the procedure is the same. The groove is created in a similar fashion as was mentioned in the study, and then full thickness graft is being done after creating the groove, because the groove, etc., has to be done when the pressure of the eye is well built up, and then you open it. So if the IOP if there was a very reasonable good hypotony in the preoperative condition, then in that case you can do an open sky fixation of the IOL. You can place the IOL because it is very easy, and you will not damage the endothelium of the donor tissue also by any means. So you can do it, go ahead and perform. But if you feel that there is some extra positive pressure, in that case, it is always better to put 4 sutures, put the graft, and then you can maybe cut the top suture and then go ahead and fix it up and complete the procedure. So, and this is the post-operative study and post-operative treatment. And this is one study wherein we showed, presented in Journal of Cataract and Refractive Surgery, wherein esophageal or glued IOL with DSEC and PK, both was performed and both was reported in this particular study. And this is the post-operative picture. And I just wanted to show you one thing that, I have done with suture technique also. But when I did the suture technique with the UBM, the lens was moving quite a lot. But here you can see the lens is absolutely sturdy. This is what Dr. Avnindra was telling, that the pseudo-phacodoneesis is absolutely negligible when you do an intrascleral haptic fixation or the glued IOL technique. So this is what I wanted to show, that by UBM, that the patient is moving the eye. You can see the section is changing, but the IOL is rock solid, sturdy in its position. So that is something which I wanted to emphasize. So what I would like to conclude by saying that this is combination of the endothelial keratoplasty with glued IOL technique is a feasible technique. The IOL remains stable. You do all the procedure, the IOL doesn't move. It remains stable in its position, even in the post-op as well as the intra-op procedure. And there is no significant chance of IOL-related graft endothelial damage as well. And as I showed that the latest study, which has been published in June 2021, that if we do a sequential procedure, then the graft survival is even better than a combined procedure. So thank you very much for your patient listening. And I will be happy to discuss and have questions.
Thank you, Dr. Sinha. Great talk, sir. It is always so enlightening to hear you speak and see these wonderful videos and presentation from you. And I would now like us all to introduce you to Dr. Avnindra Gupta, our chief instructor for this course. Dr. Avnindra Gupta is a senior vitreoretina surgeon with us at Center for Sight, and also an entrepreneur of Surgeon Power Excellence at Nayan Jyoti Eye Center in Faridabad. Sir has been one of the major mentors for all VR surgeons in Center for Sight who have shifted to this glued IOL technique. And through this presentation, I know he will take you through certain very complicated situations wherein he has used this the kind of feasibility of this technique along with his surgical skills to pass through some very tough scenarios. Over to you, Dr. Gupta, please.
Thank you, Ritesh. What I'll be talking is glued IOL in complicated situations. And along with this, I'll be talking about showing some videos of complications. So if you have situations like this, ACIOL or a dislocated IOL in the vitreous cavity, a corneal scar with an absorbed cataract, pseudophakic bullous keratopathy with an ACIOL or aniridia. The main problem is, should we leave this eye aphakic or rehabilitate this patient with good SFIOL, because most of this patient, the other eye is good. And if you don't implant the eye in these patients with the IOL in these patients, then the eye will not be functional. This is one of the patients you can see underwent complicated cataract surgery with sector iodectomy. ACIOL was placed, and this patient was a doctor, and you must not have seen any time a dislocation of an ACIOL. And because of this dislocation, the patient also had CME. You can see the fluid and intraretinal cyst in this patient. So we went ahead and did a surgery. We created a flap nasally and temporally, and we did a total vitrectomy. All the vitreous was freed from the IOL, and this haptic was held with a 23 gauge forceps and was brought into the pupillary plane. With gentle maneuver with another forceps, the haptic was held and is gently externalized. Once the haptic of the AC IOL is externalized, IOL is gently rotated. It should not be a very jerky removal because the PMA IOL can damage the endothelium and you can land up with a problematic situation. Once the and you can see I am holding the tip of the haptic, what everyone has told in this course, that catching the tip of the haptic is important. Otherwise, you will land up with kinking of the haptic or a broken haptic. The haptic is internalized. Other haptic is also externalized. A chariot tunnel is created with the help of a 26 gauge needle, and then this haptic is internalized in the chariot tunnel. And you can see the post-operative picture, a well-centered IOL. And the important thing, what I was mentioning, or what Rajesh or Dr. Venkatesh was telling us, because of low endophacodonesis, you can see that CME has regressed from before, and this patient improved to 618 vision. Uh, the problem with the sutured scleral fixated IOL and with iris claw lenses is there's a lot of pseudophacodonesis. And if you have a lot of pseudophacodonesis, the incidence of cystoid macular edema becomes as high as 33%. So that's why sutured scleral fixated IOL was not very pretty common in early days. But once as scleral fixated IOL has come, everyone has devised his own technique like Yamanei's or technique or Rajesh technique or glued IOL technique to do an scleral fixated IOL. Basically, the aim of the technique is to fix the haptic into the scleral pocket, which makes the lens absolutely rock stable. There's another patient, 12 years old male, a young male, had perforating injury which was sutured locally. Vision was hand movement, had corneal scar, peripheral antiacenekia, partially absorbed cataract, cataract with occlusio pupilli. We did a ultrasound which showed a normal posterior segment. And we started this surgery. We placed an AC maintainer because putting an cannula was difficult. And we made an introduced in trocar cannula on the temporal side. And we started cutting or removing this partially absorbed cataract. At this stage, we realized that the adhesions are pretty strong and this cannot be managed with the help of a cutter. So I made a clear corneal tunnel and went with an Vanas forceps and cut the peripheral, cut the leucoma adherents. Along with that, I did sphincterotomies, supranasal, infranasal, and supratemporally. Once this sphincterotomy is done, you can see the pupil size enlarging. You can visualize the posterior segment, and you can do a nice, good vitrectomy in this patient. Vitreous with cortex is removed. And the center portion is cleared. A light pipe is introduced to examine what is the status of the posterior pole, and you can see the posterior pole appears good. So I then decided to go in for a secondary glued IOL implant. The lens was injected with the 23 gauge with the injector. The haptics were externalized. Once both the haptics are externalized, it is internalized into the chariot tunnel. And you can see the post-operative picture, a well-centered IOL, and the vision improved to 618. And this is another interesting patient, aphakia with secondary glaucoma, underwent complicated cataract surgery. Surgical wound was from 10 to 2 o'clock position, aphakia with vitreous in AC, secondary glaucoma uncontrolled on maximal medication, planned for vitrectomy with posterior AGV. And you can see there is a wound here. There is an important thing what you have to understand. This case needs planning. So our glaucoma surgeon said, Dr. Hirsch said, I'll place the valve in the infratemporal quadrant. So he created a peritomy and sutured the valve 8 millimeters behind the limbus. Once the valve was sutured, a 5 into 5 millimeter scleral flaps were created. Once the flaps are created, we created 2 additional flaps, one in supratemporal quadrant and one in infranasal quadrant, because these were the areas available, and we'll create a corneal tunnel in the supranasal quadrant. The flaps are created, the sclerotomies are made 1.5 millimeters behind the limbus, and we started the vitrectomy. If you want to place the valve in the posterior segment, then you need to do a complete vitrectomy, uh, including removal of the posterior hyaloid. So if you want to remove the posterior hyaloid and you want to be 100% sure, you have to use tricot. And you can see we are creating an posterior vitreous detachment. And this is the V's ring. All of the vitreous is removed. A total vitrectomy is done. The tricot is removed. Once the total vitrectomy is done, chariot tunnel is made with the help of a 26 gauge needle and a 23 and a foldable IOL is injected. The important thing here is hold the tip of the haptic and don't externalize the haptic until and unless the whole of the IOL is delivered into the anterior chamber. The haptics are externalized, the other haptic is also externalized, and then it is internalized into the chariot tunnel. Once this procedure is done, a fistula is created 2 millimeters behind the limbus, and AGV valve is placed, and you can see the valve coming behind the lens. Because of the exposure of the tube, we also place, now we have started placing a scleral patch graft. Since the iris was injured, we thought we'll also repair the iris. So a CT C6 10-0 proline was taken, and the iris was enclaved and then docked into the cannula and brought out of the this paracentesis. You can see now 3 sutures here, 1, 2, and 3. 4 throws are taken, and the 10-0 proline is caught. This is what we call as a sliding knot or a Siepsel's knot. And you can see we have created a pupil. The sutures are cut and the glue is placed over the flaps. And as in all glaucoma patients, the conjunctiva is stitched nicely. And this patient improved to somewhere around 6/12 vision. This is another patient of aniridia. I wanted to show this patient at what is the anatomical. You can see how well the lens is placed. It's in horizontal position, and an aniridia patient regaining 6/18 vision. Coming to the complication, if you have an anterior sclerotomy, then you can hit the ciliary processes or the iris root, and you can land up with vitreous hemorrhage. If you have an posterior sclerotomy, you will have less haptic for externalization, and you will land up with unstable IOL and late subluxation. So the tip here is that the sclerotomy should be 1.5 to 2 millimeters behind the limbus. We have learned the hard way around over the years of experience, and I find 1.5 to 2 millimeters. I measure it from the posterior limbus 1.5 millimeter and then make a sclerotomy. Unequal distance of sclerotomy from limbus can lead to IOL tilt and resultant astigmatism. So I always tend to measure the sclerotomy site nasally, nasal and temporal. If you catch the haptic in middle, you can land up with kinking of haptic, what Dr. Ritesh has shown. And if the externalization is too forceful, you can land up with breakage of haptic And if this haptic breaks, you have to have another IUL. You have to expand this IUL and put another IUL. If you have a loss of haptic, use handshake technique, what Dr. Priya Narang, or you can use Biko technique. And another good technique, what Dr. Venkatesh has shown, you can put a silicone stoppers on the tip, so the loss of haptics will be prevented. This is one of the patients where I did a glued IUL, and 3 weeks later, patient came with aphakia, and what I realized, the lens has subluxated or dislocated into the vitreous cavity. You can see one of the haptic here, the other haptic is here. So I intend to fix the same IUL into the vitreous cavity. I open the same flaps because it's just 3 weeks old. And the haptic is caught, the other haptic is brought into the pupillary pane. It's sometimes it becomes very difficult to hold this haptic. So what we do is we do an handshake technique, hold the haptic with one forceps, the other haptic is introduced through the paracentesis, and then hold this haptic. The second haptic is also held, and now this time you hold the haptic from the tip. So while externalizing, you won't kink the haptic or break the haptics. So once the haptic is held at the tip, it is externalized. And both the haptics are externalized. You can internalize this haptic. And since there is a dislocation, what I prefer in these cases is I'll put a 10-0 suture for additional stability so that the lens does not dislocate in future. This is another patient. You can see 3 weeks to 4 weeks. You can see there is a melt of the scleral flap, and the haptics are exposed. Once you have a melting, then this patient can land up with the post-operative endophthalmitis. And this patient also had pain. So we used a scleral patch graft to cover this haptic and prevent the melting. And we sutured this scleral patch graft over the melted uh, scleral flaps. And this patient is now doing good. Many times you will see there is an exposure of the haptic in these kind of situations. You have to just open the conjunctiva and make another tunnel with the help of a 26 gauge needle, or you can use, many of us are now using a 2 millimeter and this haptic is now internalized into this chariot tunnel, and then conjunctiva is sutured. So coming to the post-operative complications, CME occurs in 5 cases, occurred in 5 cases, RD in 2 cases, scleral melt in 2 cases, dislocation of IUL in 3 cases, choroidal disinsertion in 2 cases. I dealt with expulsive hemorrhage in 1 case, endophthalmitis in 1 case. Incidentally, 2 patients developed macular hole. So to conclude, glued IUL has opened new paradigms in treating and rehabilitating young patients who would have been left aphakic with no useful vision. I'd like to thank Gabor Shariat and Dr. Amar Agarwal, the mentor of glued scleral fixated IUL, for giving this wonderful procedure. Thank you very much.
That was fantastic. Fantastic, Avnindra, showing so many complicated cases and you're coming out with very good solutions. Just one thing I would like to add here that I've seen, because we do see encounters residents doing, even I have committed a mistake. You were talking about the sclerotomy. I also use between 1.5 to 2 millimeter position. Only thing is that the direction of the entry should be directed towards the center of the globe.
Yeah.
Catches the iris. So that is something which I wanted to.
That's a very good point, Rajesh, you have mentioned. With this, I'd like to thank all the panelists, Dr. Rajesh, Dr. Venkatesh, Dr. Naresh Babu, Gitansha, and Ritesh for joining us for this session and made this session interesting. And the videos were wonderful. Thank you very much for joining us. And hopefully we'll do this course again next year, because it creates interest in a lot of general ophthalmologists.
Thank you.
Thank you.
Thank you so much.
Thank you. Thank you, Dr. Avnindra.
Thank
Thank you, sir.
I think we are on time.
Yeah, we are absolutely bang on
Sir,
time.
we are absolutely bang on time. It's 3:55.
Thank you.
Thank you, Rajesh. Thank you, Ritesh.
Thank you, Ajay.
Thank you, sir.
Thank you, Venkatesh. Thank you, Naresh. Okay, bye.
Bye.